glad. We appreciate Dr. Marusco being with us today with Cross Timbers Orthopedic from Stephenville, doing clinic now at our hospital, which we very much appreciate. Very good for our community, and very happy he's here. Dr. Marusco graduated from University of North Texas Health Science Center, basically rural education, correct? Board certified in clinical practice, also fellowship trained in sports medicine. So really kind of unique perspective on things. We actually did some training here, correct?
Yes.
You were here with Dr. Wilkerson.
Correct.
So he's been kind of a part of the community already, prior to us actually, working behind the scenes here. Anything else you want to tell them about you? I think everybody knows.
Yeah.
So, okay, probably have somebody who's seen them.
Right.
Okay,
I appreciate it. Thank you all for coming today. I really appreciate it. Okay. I wanted to introduce a couple of people in the room that helped make my job a lot easier. Elvia Gutierrez, who's my medical assistant, and then Heidi Rivers, who you've seen checking in. She also does a lot of the billing and coding and things like that for us. So happy to have them here as well. And again, thanks for spending your time with us today at lunch. The topic today, as you can see, is going to be treatment options for OA, which is just an acronym abbreviation for osteoarthritis. We'll kind of talk a little bit about the process behind osteoarthritis. What is it exactly? What causes it? And then what are some traditional treatments out there that we can go to that are typically covered by insurance providers? And then talk a little bit about the new stuff that's out there on biologic and cell therapy, things like PRP and stem cell injections, because I know that there's probably a big interest in that, and I've attended quite a few seminars in that, and I'm anxious to start doing that in the next month. So kind of the nature of osteoarthritis, the nature of the problem, you've got a combination of biomechanical and biochemical issues going on. Usually, if you've had some sort of injury, that could be a setup for osteoarthritis, trauma to the knee. We see a lot of people in their late 30s, 40s, and above, of course, that have had some sort of traumatic injury playing high school football or some other sport, maybe even an ACL tear. Well, later on in life, you can rest assured that they're going to be suffering from some sort of osteoarthritis in that knee as opposed to the other knee, even if they have surgery on it. Okay, so that knee is always kind of against the odds to begin with. And other things in regards to biomechanical, sometimes people will have a little bit of malformation of their knees, alignment as far as do they have bowed knees, do they have knees that are knock-kneed, and that puts extra strain on one side of the compartment than as opposed to the other. Weight gain also puts extra strain on the knees. Also, if you have any type of muscular deficiency or inflexibility, those things can be addressed, diagnosed by myself, and then sent to physical therapy. Physical therapy has a crucial role in helping to correct those deficits so that the osteoarthritis can be slowed down and the pain can be reduced. This is just a little quick slide that kind of explains everything to you about how you've got all these multifactorial processes going on as far as the abnormal stresses like we spoke about, obesity, you've got bony remodeling, you've got osteophyte formation, or little bone spurs that develop, and of course anatomic abnormalities, bowed legs, knock knees, trauma. That goes into your abnormal stresses, abnormal cartilage. Obviously, the knee is kind of seen like a machine part. The way I describe it is kind of like brake pads on a car. You know, the cartilages are kind of like the brake pads, and eventually they're going to wear down just from overuse. You can't deny that. And so there's also things in regards to genetics. Some people will develop osteoarthritis as early as the early 30s, and usually you can trace that back to some sort of genetic issue going on there, and that's something to keep in mind. inflammation, whether it's the diet that you're on. There's various foods that are out there that you can try to avoid that will kind of help keep control of that inflammatory cascade that can cause knee pain. And then immune system activity. We're talking strictly about osteoarthritis, not so much about rheumatoid arthritis or gout or some of those other things that can be caused through a biochemical process, through uric acid overproduction and things like that. And if you have any questions, we're going to have a session at the end where I'll allow time for you to ask questions. Just kind of keep that question in mind, and we can always go back and answer that. Just a diagram kind of showing you what's going on with the process of osteoarthritis. The articular cartilage is the blue lining that lines the joint surface, and you've got joint fluid in through here. Okay, this is your meniscus, and as you can see, over time, that meniscus starts to wear, becomes thin, more and more thin, and then the articular cartilage becomes exposed, and that leads to the pain because then the nerve fibers are exposed. So some of the things that we can do to treat that are putting medicines into the joint to cushion the knee, addressing muscular deficiencies in the knee, okay, bracing so that you can somehow unload this portion of the joint by pushing or pulling on this side. And then, like we talked about, eventually getting into cell therapy where you can inject things from your own body to try to replenish that cartilage, okay? Just some pictures, x-rays of osteoarthritis, primarily of the medial compartment here. The lateral compartment is nice and wide, as you can see on this film. So what we try to do is attack and treat this medial compartment, which is the most common area to have osteoarthritis because that's the main portion that bears the weight, the medial aspect of the knee. So you can use a pusher or a puller brace that will help to decrease this space, but mechanically widen that space. Okay, we do have, at Cross Timbers Orthopedics, we do have what we call a brace expert that comes on Friday afternoon, just about every Friday during the month, to help us out with getting you in the right type of brace. There's hundreds of different kinds of braces. The ones over the counter don't come close to the ones that we have and that he can get for you because they do have a device to where we can widen that space there. Some people also have osteoarthritis under the kneecap, and that's called chondromalacia. You can't really lift the kneecap off of the tibia and the femur, but what you can do is keep that patella stable and tracking midline. Because sometimes if it tracks laterally or medially, that causes pain and grinding underneath the kneecap. Usually you can address some muscular deficiency, meaning maybe they have weakness on the inside of their quad as opposed to their outside, and that's causing the kneecap to track more laterally. Again, physical therapy comes in handy when you have a deficit like that. Okay? Traditional treatments, these are things that are typically covered by insurance. Okay? We'll talk about various types of oral medications. Okay? Corticosteroid injections, bracing, we've already spoken about that just briefly. Physical therapy as well, and then visco supplement injections, which we do quite a few of those. Okay? Your most common medication to treat osteoarthritis pain is going to be your non-steroidal, or NSAID for short. Those are things like your ibuprofen, naproxen, aspirin, and Celebrex. So yeah, even aspirin is seen as an NSAID. Some of you may be on an aspirin, mainly for prevention of heart attack and stroke, just a baby aspirin. You can also consider going up on the dose of your aspirin. It gives you the cardiovascular protection, plus you can use it as an anti-inflammatory. Okay? A little harsher on the stomach than some of the newer NSAIDs, but all of them unfortunately do increase your chance for heart attack and stroke, okay, across the board. Now, some of them have a lower risk profile than others, and so whenever you come in to see us, we look at your past medical history, we look at the medications you're taking, and we try to get you on the medication that's going to be the safest for you. For example, Celebrex is a great medication. In terms of cardiovascular risk factors, it's just about as equal to naproxen, your good old Aleve over the counter. And if you take Aleve the right way, you can get just about as good of benefits. Celebrex does help prevent stomach ulcers. Okay? So the leading cause of death from use of NSAIDs is not heart attack or stroke, believe it or not. It's from GI bleeds. And usually it comes on fast and it can happen suddenly. And then before you know it, you're in the emergency room and having to see Dr. Simpson or another general surgeon to have that fixed. So that's something to keep in mind. Okay? Acetaminophen, a lot of people come in and they say, I've tried Tylenol, but it's just not helping. Okay, the current recommendations on Tylenol is no more than 3 grams of acetaminophen in 24-hour period. So a lot of times people will just take one 325 milligram tablet maybe every 6 to 8 hours. And in my opinion, they're just not giving it the best opportunity to help them. So sometimes we'll have to go up to extra strength Tylenol 2 tablets as often as 3 times a day. Okay, much lower risk profile in regards to heart attack and stroke. So I like to maximize the benefit of acetaminophen as opposed to the risk that you can get from NSAIDs before we move on to some of the riskier medications. So opioids, those are all your narcotics, your pain medications. Occasionally we'll prescribe those primarily for post-operative issues or significant trauma, fracture, things like that, and for just a short period of time. Opioids, they're kind of a slippery slope. They do tremendous amount they provide tremendous amount of relief for pain, but the problem is that they do have addictive properties that you have to watch out for. Okay? Tramadol is probably one of the safer of the group. It is a mild mu opioid receptor agonist, so less likely to develop dependence and things like that than say your Tylenol with codeine or hydrocodone, norcothane, things of that nature. So we try to reserve those for recalcitrant pain that isn't responding to other medications that are a little bit safer. Topical NSAIDs have become fairly popular over the last couple of years. So now they're able to take some of these medications that you would take orally. Pharmacists can mix them up, however, whatever combination I need in the mix with lidocaine or perhaps ketoprofen, naproxen, and then you can apply it directly to the area that's experiencing any pain. Okay? That makes it a little bit safer because you bypass the gastrointestinal tract, so you're less likely to develop ulcers. Now, for people with renal issues, kidney problems, you still do get systemic absorption, and so you still have to watch your kidney function. Alternative medications, okay, glucosamine chondroitin. One study just recently came out and found it to be equally as effective as ibuprofen or Aleve in some cases. Again, it's finding the right product, knowing how much to take. I've found that probably anywhere from 40 to 50% of my patients respond well to oral glucosamine chondroitin supplementation. Sometimes people take it, they just don't give it enough time. It'll often take as long as 8 to 12 weeks of taking it on a regular basis before you notice any significant improvement. Okay? They have new products out there now. It still will cost you around $30 a month or so, but it's a good investment. You take 1 large capsule a day. Okay? And I have a list of those kind of supplements that I recommend, along with fish oil, which is also good for cardiovascular system, keeping down your triglyceride level, heart health, so on and so forth. Turmeric is another one of those. It's a natural herb. It's used in seasonings and things like that for food. It's been around for a while. They're starting to mix that in with the glucosamine and chondroitin, and it's a natural anti-inflammatory for overall joint pain. Okay, various products out there too, and I've kind of done some research to try to keep up with the ones that I like and the ones that I don't care for quite as much. So the nice thing about these is that they really, really have a low risk profile. So, if you can get on something like this, I see these as kind of like a vitamin supplement. Okay, we'll talk about visco injections for the knee here in a little bit. The glucosamine chondroitin is kind of like a vitamin supplement for your natural joint fluid that you already have. Okay. Sometimes it causes a little bit of GI upset and occasional constipation, but you can kind of alter that when you take it with food, or if you take it at bedtime, that usually will lower those risks. Okay? Corticosteroid injections, they've been around for a long time. Everybody that suffers from osteoarthritis pain flares will know that a lot of times this is kind of your saving grace. When you're having really bad pain, you can't control it with oral medications, you try to stay off of it, it's swollen, it hurts to even touch. If it's not an infection, then you can always do what we give is a Celestone or Depo-Medrol injection. Those are just two different types of corticosteroids. One of these is more pure, one of them has a little bit more precipitate in it. And so you kind of have to have a little knowledge in that area in regards to which one is the best one to give for you. Because they're not all the same. Some of them are short acting, some of them are intermediate acting, some of them are long acting. But they do usually provide you with very fast acting pain relief. The problem though is that they're short lived. They don't last for months at a time, typically. Your first one or two in a knee may last you a couple of months. But the visco injections are the ones that kind of take over from that point and give you longer pain relief. Okay? We still aren't sure exactly why they work, but they are covered by insurance providers. Okay? And I say that because that's pretty important. Right now, insurance providers don't cover the cellular therapy like PRP, platelet-rich plasma, or stem cells. Okay? Several studies are showing a lot of success in this area, but it's at the very frontier, the very edge of medicine as far as what's the correct protocol to use. Okay? But they do cover corticosteroid injections even though, there's no really proof that they actually work. Okay? But from clinical experience, they do. Now, if you get too many of these, you usually can only give an injection, a corticosteroid injection in the joint about every 3 to 4 months. It can worsen your osteoarthritis, and it can also cause issues with blood supply to the bone, and it's called avascular necrosis, which ends up resulting in you absolutely having to have a knee replacement or a hip replacement. So you don't want to get those too often, okay? And for somebody that has uncontrolled diabetes or even regular diabetes, you have to give kind of a lower dose, and you have to watch your blood sugars and things like that. Some of the other cellular therapies, the blood shot, which we'll talk about, equally as efficacious to a corticosteroid injection, but really no side effects. Okay, doesn't elevate your blood sugar, so that's pretty cool. Okay, bracing, we kind of briefly spoke about that earlier. This particular diagram shows a lot of medial joint space narrowing, so severe bone-on-bone apposition of the medial compartment. So this person got a brace, and as you can see, there's a force here pushing on this side, the outside of the knee, force up here, and that will artificially widen the space there in the medial compartment. Now, these braces aren't meant to be worn 24/7. Typically you wear them 6 to 8 hours a day when you know you're going to be on your feet for an extended period of time. But it will help with relieving the pain because this cartilage that's no longer there, you no longer are having force pushed on those pain receptors at the end of the where the articular cartilage used to be. Physical therapy. Y'all are very fortunate to have an outstanding physical therapy center here. We have options, of course, in Stephenville because we have patients that come from all around, and I've had experience with different physical therapy centers. And Mitch and Brooke and the rest of the staff, they do an outstanding job for our patients. And I'm happy to have them around. You also have the advantage of having a little hydrotherapy, a little water station where you can actually get on an elliptical machine when you're trying to rehab from post-operative surgery, or if you just are having so much pain that you can't do full weight bearing due to gravity. It makes it's a big game changer. Okay, I think they're also starting to do some dry needling techniques, which is a technique where you can use kind of like acupuncture needles with a small burst of kind of electricity for muscle spasm. Okay, we've used that quite a bit on the athletes that we care for at Tarleton. We take care of all the Tarleton athletes, and then probably about 10 high schools in the area, and Ranger College as well. And we have a lot of people that will have significant neck spasm or low back pain, usually football related or from lifting heavy weights, and that's just a tool that you can use. But they do a great job for us.
Thank you, doctor.
Sure, no problem.
And we appreciate all your referrals also.
Oh, you're fine. Okay. Visco supplement injection. So this is the term that we use for what you probably heard, layman's term, of the rooster comb injection. Okay. Now there's various kinds available now. The first one was Synvisc, and it's the thickest one on the market right now. Second would be Hyalgan. Those are truly derived from the rooster's comb. Okay, so they're avian derived. You have to watch out if you do have an egg allergy, poultry allergy, or any type of allergy to like the flu vaccine, then you have to go to an alternative agent. There's about probably 7 or 8 out there that are really good. We use probably 5 of them. So just because you may have failed one particular type of visco supplement injection doesn't mean that they're not going to work. So a lot of times what I'll do is look at other products available. If you tried an avian product and didn't get relief, then I'll switch to one that is basically produced by cultured bacteria in a lab, and they actually make the hyaluronic acid, which is the main component in your joint fluid. So all we're trying to do essentially is, as we get older, after about the age of 30, believe it or not, the joint fluid starts to get thinner and thinner. Okay, so the viscosity goes down. So then at that point, it's not doing the job it needs to protect the articular cartilage like I showed you earlier. So we're essentially putting in a thicker agent, okay, to help cushion that area. And also we'll remind your cells in a way to start making thicker fluid again. So that's what's indicated every 6 months. Sometimes you can push it to every year for those individuals that seem to be responding well and aren't having any pain until about month 10 or 11. So then that's a possibility. So as we talked about, they do protect the pain receptors and the cartilage. It helps slow the progression of arthritis. There's not a cure for arthritis, okay? This is something to help put on the brakes, so to speak, okay? It inhibits the inflammatory pathway, and then as we talked about, it serves as a shock absorber by increasing the viscosity. Usually, there's one shot series, which is a large volume. Most of the clinical studies don't show that to be quite as effective as like a multiple shot series of 3 or 4 or 5, okay? Usually, most of what we do is a 3-shot series. That's 1 shot a week for 3 weeks, okay? You can do 1 every week or 1 every 2 weeks, times 3. Repeat those every 6 months, okay? Occasionally, if people have had the 3-shot series, say 2 or 3 times over the last couple of years, and their pain comes back around month 4 or month 5, then sometimes we'll push it out and do a 4th one, because usually insurance providers will cover that. The initial series may be a little expensive depending on your insurance, but then once you meet your deductible, it's pretty manageable as far as the cost is concerned. Okay, a few adverse reactions. Occasionally you'll get some GI complaints, maybe headache, a little local reaction. We call it a pseudoseptic joint reaction, where it's basically looks like it's an infection, but it's not. And I have the most issue in regards to the 1-shot series, primarily Synvisc for whatever reason, and that's the one that's the avian derived. Pretty easy to treat, but once you have it, it makes you kind of hesitant to keep getting them. But if you switch to one that's not avian derived, then it doesn't usually become a big issue. Okay? Before we move on to cell therapy, are there any questions as far as traditional therapies that maybe you had at this moment that you'd like me to address before moving to the next topic? Okay? If you think of something, feel free to ask at the end. So cell therapy, again, that's going to be talking about PRP, platelet-rich plasma, which is essentially a blood draw that we spin down and concentrate the cells that you need to get better and then inject them into the knee, not stem cells. And then you get into talking about stem cell therapy, which are true stem cells. There's different types. As you'll see, there's embryonic, and then there's mesenchymal, which are basically derived from your own body. Okay? Platelet-rich plasma, it's autologous blood. That means it's taken from your body, okay? Usually about a 20 to 30 cc blood draw. You spin it down. All of these cells, your white blood cells, red blood cells, platelets, serum, plasma, they all have different densities, they have different circumference of the cell, and through a centrifuge process, you're able to concentrate the cells that you need to help get you better, basically. All right, then you take those cells and you inject them. It's usually about 5 cc's, and it comes out like a kind of like a yellowish gold looking serum, and that's purely platelets with a few white blood cells and some plasma. You essentially get rid of the red blood cells and you get rid of most of the white blood cells. Okay. The nice thing about platelet-rich plasma, it's been around for a long time, as we'll talk about in a bit, but you can kind of fine-tune what it is that you're trying to treat. If you're wanting to treat a soft tissue injury like a muscle strain or tear, ligament tear, tendon tear, you can increase the concentration of white blood cells for that particular issue. If you're wanting to treat something that's more chronic in nature, like osteoarthritis, then you decrease the number of white blood cells with your platelets. And so essentially you're able to fine-tune the type of treatment you're providing. Okay? We have used ACP, which is autologous conditioned platelets, since I've been at CTO for the last 3 years or so. And we've had good luck with that. But technology keeps advancing, and we're now about to start offering the PRP, which I think is going to be more of a precise treatment for what it is that we're treating. Stem cells, embryonic, which essentially, FDA has strict regulations in this regard. When I say embryonic, I'm talking about the amniotic fluid and also the placental lining on the baby side. Okay, so the babies are fine, they're healthy. The mom donates the placenta instead of discarding the placenta after birth. They donate them, and you get a lining of that placenta that has stem cells. Okay, those stem cells are pluripotent, meaning that they can turn into any type of cell: cardiac, nervous system, bone, cartilage. That's the advantage of those. The disadvantage right now with embryonic stem cells or the amniotic fluid cell is that once these aren't living cells anymore. They take them, they freeze dry them, or they store them in really cold temperatures to keep them fresh. Usually about 70% of those cells will die. So you're not going to get all of those cells back. Okay, another issue that I have right now with it is you aren't able to turn off the potential for a carcinogen or a cancer to develop. You don't know if those individual cells have the potential to turn into a tumor at some point. Okay, most of the labs do try to screen them as best they can. We've done a few of these, and I've had probably 20 to 30% reduction in pain for people that have end-stage osteoarthritis that probably needed a knee replacement, but they came to me requesting that we do that. And so I've had mixed results with it, okay? But some people are offering that now, and maybe they'll get better in that regard. Mesenchymal or mesenchymal, those cells are adult stem cells, okay? You can get that from bone marrow, or you can get it from adipose fat, okay? They're living cells. You harvest those cells in a clinic, you take them out, and then you inject them into the affected joint, okay? So usually marrow and adipose, and we'll talk about the advantages of either one. Going back to the PRP, again, a blood draw, about 30 to 40 cc, spin down, concentrate the platelets, and that has the whole blood. Take out the platelets, growth factors, and plasma. White blood cells for the most part, and red blood cells you discard. And as you can see, it enhances the recruitment of tendon cells, cartilage cells, and even stem cells. It will attract those to the area. So that's why, when you see people advertising stem cells and things like that, you've got to kind of know the science behind, okay, what is it that they're wanting to do? So PRP, the blood component, is not a true stem cell injection, but it has signals that when you inject it to that joint, that calls your stem cells from your marrow to that area, okay? Okay, just to review, within the blood, you've got your cellular elements and then the plasma elements. Again, pretty much getting rid of these two, keeping the platelets, keeping the serum, and then you've got fibrinogen, clotting factors, you've got cytokines, things like that. They're essentially going to help with the anti-inflammatory process when you inject it either into the soft tissue or the joint. And this is just kind of a slide showing the different steps of what you do, the blood draw, the centrifugation process, inject it into the rotator cuff or the shoulder joint. This is kind of what it looks like. This goldish serum is what we're trying to obtain, and then the end product over there if you double spin it. Again, we kind of talked about you obtain it through cell size and the diameter. When you collect the blood and you centrifuge it, obviously the heavier cells are going to settle down, so you get your red blood cells, the buffy coat, which has mainly your white blood cells, and then your serum with the platelets, and then you concentrate that again, spin it down, and then you get the PRP that you're able to use. Okay. Stages of tissue healing. Obviously, one, let's say you sprain your ankle. What happens right away? Your ankle hurts, it gets swollen, you get some bruising. All of that is part of the injury process. So when we are injecting PRP, it's not going to give you immediate pain relief. It's not like a cortisone injection. This is usually for something that happened a week or two ago or several years ago. And so what we're trying to do is restart or kick back up the inflammatory cascade, because that's the first stage of healing. Okay, so I have to explain to people, you're going to get more swelling, you're going to have some more pain, but then it's going to be a roller coaster for the first 2 weeks. Then it'll get better for a few days and it'll start to hurt again. And after about 2 to 3 weeks, it starts feeling better. Okay? Because then you start getting into the step 2, which is where you start to develop your cellular matrix, start making new tissue, and then tissue remodeling of that particular area where the injury occurred. So just a little history on PRP. As I mentioned earlier, it's been around since the 90s. Maxillofacial surgeons would use it whenever they would have somebody that would have a catastrophic injury and they would have to have skin grafting, reconstructive surgery of their face. And usually they'll take skin grafts and adipose from other parts of the body to rebuild the face. The fat and the skin would not survive without PRP. And that's where it started. Okay? And then we started to realize, hey, their scar has lessened whenever we use more of this cellular component with it. And so they were the first to use it, and then it's kind of fed into the sports world. Okay? I had the opportunity to do my sports fellowship in San Antonio with some really good docs that take care of the Spurs, and they were using a lot of this 3 and 4 or 5 years ago, along with the visco injections, specifically with Tim Duncan, and allowing him to continue to play as long as he did. Okay? Concentration of platelets and growth factors, it's usually anywhere in the order of 3 to 8 times the concentration. Okay? And we'll talk about why do you necessarily need the platelets. So, and this talks about the steps that we briefly spoke about as far as an injury to a joint. Platelets collect to that area. When the platelets collect to the area, they then rupture. They release these alpha granules, the alpha granulars. Granules then release growth factors and signals to your helper cells to come to the area, including stem cells. And that's what allows your body to recover from an injury. So essentially what we're doing is just taking your cells and helping your body out just a little bit by concentrating those and giving it a little extra boost. Okay? So platelets, we use those with serum as a delivery vehicle. We inject them into the joint or the tissue. This will eventually, once they rupture, they send off their signals. You'll start to develop more collagen, protein regeneration, initiates and kicks up the inflammatory cascade through all the phases. And overall, it will decrease blood loss. It is antimicrobial, so it decreases infection rate. So a lot of times, after an operation or sometimes during an operation, for Dr. Evans, he will do this at the time of an operation or 2 weeks following the operation when they come back for a wound check. Mainly because of the healing components to help you speed up the healing process, but also anti-inflammatory aspect. and it doesn't, if you use an anti-inflammatory medication, that's going to stunt the healing process. But this is a way to use your own cells to encourage that process to continue, but keep the pain level down after the initial injection. And then also prevention of infection. So how are we using PRP now? Multiple things, tendinopathies. Usually if somebody has recalcitrant tennis elbow, plantar fasciitis, Achilles tendonitis, patellar tendonitis, issues with the rotator cuff where it's not a complete disruption. These are things that we'll go to with the PRP. Okay? We still use the traditional model of medicine where we go through the things step by step that are covered by insurance. Okay? We want to try to keep the costs down. But when we get to the point where we've tried everything known and there's nothing else to try but surgery, we'll try the PRP injection before we go to the last step, which is surgery. Okay, our goal is to get you better without having to do surgery. Sometimes it's inevitable, okay? And you can use the PRP afterwards. But for the most part, PRP as opposed to a corticosteroid, if you inject it around the tendon, increases your chance for tendon rupture. PRP does not, okay? Long-term pain relief, PRP is far superior to a corticosteroid injection, which can wear off in a short amount of time. Usually it's a series of up to 3 injections spaced about every 2 to 3 weeks apart, okay? Muscle strains, talked about osteoarthritis. It can heal bone a lot faster, so a lot of times we'll have an athlete, say a track and field athlete, that will come in and they'll have a stress fracture of their tibia, okay, which can be a season-ending injury for an athlete. It takes much longer often for certain types of stress fractures to heal than it does if the fracture just went ahead and broke all the way through the periosteum. The periosteum is a lining of the bone matrix. If that periosteum is still intact, it doesn't break, and so those cells, the platelets, can't get to that bone to help heal. So sometimes what you can do is take your PRP, inject into the periosteum where the fracture, the stress fracture was, and then inject the PRP, and that will help kickstart the healing process to get it to heal faster. Okay, so then they can get back out and do what they love to do. Some people are using this in aesthetics for scar reduction and also for even regrowth of hair because it does attract stem cells to the area. Okay, and why PRP for OA? Well, basically you're trying to correct this catabolic process, which is a breakdown of tissue and cells, and try to kickstart an anabolic process, which you're trying to regenerate some of the cellular matrix within the cartilage. Okay, and that's basically what it's showing down there. It also decreases pain by decreasing the amount of something called substance P at the cellular level, which is responsible for causing pain. It will increase your HA, which we talked about viscose supplement injections. HA is a hyaluronic acid. So it will increase the natural production of your own cells to make more joint fluid and more thicker joint fluid. And it is superior head-to-head studies between PRP, HA, and corticosteroids. Improves function as well. Again, the only issue with this, and the reason why we don't go to that first off the bat, is because of the cost. Okay, the kits themselves to make produce PRP can be fairly expensive. You know, they can run anywhere from $200 to $500, and so that's the limiting factor right now. I think eventually insurance will cover it, but right now they don't. I always like to look at the negative side of things too, because not everything is perfect, and so these are some of the current flaws. They're difficult to study right now because really you're going by subjective data based on a pain scale reported by a patient. If you had, in a perfect world, it would be ideal to be able to repeat an MRI, say 6 months or a year down the road, and in some studies they are able to do that. Not all PRP is equal. There's probably 40 or 50 different systems to harvest PRP and different kits out there. All of them use a different method to concentrate your cells. So that's a lot of different variables. It's not all the same process. We're still trying to figure out, well, what's the best concentration of platelets for this issue, white blood cells, growth factors, how much volume do you use, how often do you do it, how frequent do you do it, how many injections do you do. So every year we go to a large scientific seminar and we start learning more and more about this, okay? And we talked about subjective data. The interval of injections, most people are doing, like I said, 3 injections about every 2 to 3 weeks apart, and we'll kind of base the number on your response to the first 1 or 2 injections. Some of the products aren't regulated by the FDA. Unfortunately, you have people that aren't even licensed physicians that are offering this, and you have to be careful of that because not all of the systems are endorsed or backed by the FDA. So there is something missing with PRP that we can still take it a step further. And as we talked about, that's the fact that we're missing the seeds. You have to have the cell to regenerate new cartilage. Okay, PRP acts as a chemical or acts as a way to communicate with your already existing stem cells to come to the area. But what if you could take some cells and concentrate them in the area? And that's where you get into stem cells. So basic science behind that, they're undifferentiated blank cells. They haven't been programmed or told yet what to do. What kind of cell are they going to turn into? Talked about embryonic, okay, and then adult. A little bit of the embryonic again, that's the placental lining cells that you can purchase and inject. Still fairly expensive. And then the adult undifferentiated cells from marrow or adipose. And as you can see down here, blood, bone marrow, adipose. There are some stem cells in blood, but really not enough to make a big deal about it and say that, hey, this is a stem cell injection. Pluripotent stem cells, these are from the embryonic stem cells. Fertilized egg, take those cells out, you can make nerve cells, hearts, cardiac cells, or even more blood cells, okay? That just means that they have the potential to become any type of cell you could ever ask for or want, okay? Adult stem cells are programmed only to become the type of cell that you put them in, that whichever environment you put them in. So usually it's going to be cartilage, ligament, bone, occasionally muscle as well, okay? They have the ability to repair tissue and secrete growth factors and also treat tendinopathy. So for the marrow component, as you move down the body, the marrow has less stem cells in it as you move down. So the sternum actually has the most stem cells. That's a difficult, very compromising area to try to inject and aspirate. So the best area that we found is the iliac crest, which is going to be just right in this area. Okay. Why? Because at the same time, if you move about 2 inches forward, you can also get a little bit of the love handle, which is where you get your adipose. So fat cells, you can get stem cells from the fat. You also get stem cells from the marrow. You do it all in the office, no general anesthesia, just local anesthetic, and it takes about an hour or 2 to do it. And you aspirate the cells that you need, and then you can inject the joint that needs the stem cells in it. This is mostly what we're doing now, is cell therapy. You inject into the knee joint or the tendon, wherever it is that you're doing. There's also tissue engineering, where you've probably heard of some people being able to regrow a new ear and things like that. That's more from embryonic stem cells, and that's more of the tissue engineering. Now, some people are also doing, people that have multiple sclerosis and rheumatoid arthritis. There are some people using stem cells obtained from fat and marrow and converting it into an IV to go into the entire circulatory system. And we've had some improvements with that. That's not my area that I deal with, but just so that you know, some people are using IV therapy with stem cells. This is just kind of an analogy, or just kind of putting things into simple terms. What are the key elements needed to grow a vegetable garden? Obviously soil, water, you need a source of energy, sunshine, seeds, and fertilizer. Okay? And then I'm trying to compare that to the elements that you need for, say, trying to treat knee osteoarthritis. So the increased blood flow through revascularization. Usually we'll have the patient individually drink lots of fluids before they come in for the procedure. That's going to increase the blood flow within the cardiovascular system. We also offer we have a class 4 laser therapy, which basically is concentrated infrared light waves that helps with vasodilation. So basically the blood vessels are able to dilate, okay? That increases blood flow to the area. So PRP after laser therapy and then the laser therapy after PRP will enhance the effectiveness of the PRP. Cellular signals would be your PRP. That's also the energy that is going to supply the stem cells. Scaffold. So you have to have something for the stem cells to stick to, and that's the adipose tissue. Even though adipose does have some does have some stem cells in it. In fact, fat has more stem cells per ounce than marrow. The issue, though, is that you need certain proteins to turn those stem cells into cartilage and bone and muscle. Marrow stem cells are more likely to take on that role when you put them in their environment. So we're using stem cells from both, plus the fact that you can use adipose as a biomatrix for the cell to grow onto, and also a form of a cushion into the joint. Of course, stem cells would be your seeds, and then the PRP is like the fertilizer. So after you have a stem cell procedure, usually about every 7 to 9 months, you will inject a PRP to kind of nourish those stem cells as they start to grow. So we call it the stem cell PRP cocktail, a mixture of stem cells you get from adipose bone marrow with your PRP that serves as the vehicle to deliver the stem cells to where it needs to go. Also provides with the energy, and then we get them from the love handle bone marrow done in the office and legal by FDA standards if minimal manipulation. So if you take the cells out, mix them, and then inject them, it's legal. If you take fat out and you process the fat, you add collagenase, which is a chemical that helps dissolve the glycerin and the thicker components of the fat, that's illegal. Even mechanical manipulation of the fat is illegal. So if you were to take the fat and then somehow grind it up, mix it up, and then get out the cells, you can't do it. So fat is a little bit more rigorous than marrow. Okay? So we have to make sure that whatever system we're using is FDA approved. And right now, there are some systems out there that are not FDA approved, and so you have to be careful of that. As we talked about, 40 times more stem cells in fat compared to a gram of marrow. But the key is stem cells from marrow are more likely to develop into cartilage, which is very important for treating knee OA. And then, of course, the fat can serve as a biomatrix, scaffold, and a cushion for the area of the joint that you're trying to protect. Okay, not everyone's a candidate. It helps treat OA. It's not a cure. Okay, so just because you get a stem cell injection doesn't mean your OA is gone forever. What we're trying to do is decrease your pain, regenerate a little more cartilage, and make your knee more functional. Okay? In most cases, it can prevent surgery, but it's not a guarantee. Okay? It's not covered by insurance. Most of the companies that I've spoken with are having about a 75% success rate in terms of pain reduction and function. Okay? If you were to MRI the knee, say 6 months down the road, you would probably see some space widening and some regeneration of cartilage. And again, we consider that if we tried everything else that we already spoke about. Most people don't see benefits until probably about month 2 or 3. Remember, this is a cellular process, which is a slow process. It's not a medicinal process, which usually is fast acting, but then slow to turn off. Are you a candidate? Well, we basically will base our decision on your physical exam, how much motion do you have remaining in the knee, and also by looking at just a plain, simple standing radiograph or x-ray. I'm here Wednesdays, and then Stephenville the rest of the week. A few colleagues of mine, Dr. Paul Sines, he's a mentor of mine that I trained under in San Antonio. He's primary care sports doc, non-surgical like me for the Spurs and also the Missions, which feed the San Diego Padres. Dr. Davis is at UC Irvine, and he gave me some of the information regarding the Visco supplement injection. And then Dr. Kumar, he's with Terumo BCT, which is a company that's produced by Harvest for harvesting PRP and stem cells. And he's basically a biologist. Questions? Anybody have any questions? Yes, ma'am.
My husband just had a total knee replacement, and Dr. Evans did it. And
Okay.
It's lovely.
Okay.
But his knee, it's been a month.
Okay.
His knee is hugely swollen,
Okay.
and it's really hard to bend. He had a spinal headache for 2 weeks right
Okay.
after surgery, but so he was kind of delayed. Is the PRP, do you ever do it after surgery?
We will do it after surgery. I'm not sure about the use of it in a replacement. Depending on where the swelling's coming from, if it's like a bursa that's enlarged, or perhaps the swelling's due to tendinopathy or tendinitis, I think there's a possibility that you could utilize a PRP injection. I guess the next question I would have is, have they utilized PT?
Oh, yes, he's
Okay.
there now.
Okay, good.
You might be able to hear him scream if
Oh,
we're
yeah.
real quiet.
Yeah. So, I mean, I think it would just be a matter of, having a look at Dr. Evans' note or talking with Dr. Evans and kind of reviewing the case and seeing if it would be a possibility. But typically, when you do a knee replacement, you cut through a lot of that anatomy. And so the PRP won't work quite as well as if it's just a simple meniscectomy where you take out a portion of the meniscus or fix the meniscus. But usually 2 to 3 weeks out after is usually the ideal time to do it. So I hope I answered that.
Yes, we did. Thank you.
Okay. Anyone else?
Is there any advantage to the PRP without the kit to mix up with if you just injected your own serum with that?
Some people have done that. The issue is, you don't know what your concentration of cells is. So you're trying to get your platelet count to at least 5 times the concentration. And then if you inject too many white blood cells and red blood cells, it can actually add fuel to the fire. So, but I have had colleagues that have done that, and there are ways of making your own. It's just to set up the lab capabilities of doing it. It's also a pretty hefty investment of around $7,000 to $10,000 to do that. Whereas the kit, like I said, can run $200 to $500. If you start doing a lot of them, then it may be advantageous to set that up. So yes, it is possible.
So you said it's would be like 3 different times of going to have the shots, right? So it would be 3 separate kits?
Correct. For the PRP specifically, it's typically three separate times spaced 2 weeks apart. So that
So
would
3 times you would draw
blood,
the blood.
and it would be 1 kit cost for that. The stem cell injection is usually 1 shot in a lifetime. I've seen a few times where you repeat another second stem cell injection about a year out, but every 6 to 9 months, it's recommended to do the PRP, the blood kit, to help basically nourish the cells that you put in. And it just makes it more effective and kind of speeds it up. But it's not an absolute requirement. So it just depends on if you're doing stem cell, if you're doing PRP, and what you're treating. So that's our decision, and then we'll kind of give you a recommendation. Yes, sir.
if you're nearing 80 years old, I don't think you need to get into that.
Well, like I said, it depends
You're-
on, you're talking about stem cells, or it depends on your x-ray. You know, some people see it as an opportunity to get better without having to do surgery, okay? There's no age limit on when you can do it and get relief from it, or get benefit from it. So we also look at the fact of, you know, if you're maybe 60 or 70 and you're really close to being bone on bone, then often we may recommend to go ahead and just do a replacement and fix it. Because you don't know what tomorrow holds. Hardware on a knee replacement lasts anywhere from 20 to 25 years. So if you can get to 60, 65, you know, the chances of you having only one operation with Dr. Evans is pretty high. Some people don't have that luxury. They may have a cardiac issue, they may have kidney problems, they may not do well under general anesthesia. So this offers you an alternative to surgery if you're a candidate based on your x-rays.
Any other questions? Doctor, thank you. This is one of our largest.
Good. Well, thank y'all for coming out. I appreciate that.